Good afternoon, everyone. I'm Dr. Praveen Kumar, Manager Market Access and Advocacy, SAT India. On behalf of SAT and AO Alliance, we would like to welcome you all to this live webinar series on advances in casting and splinting. A quick introduction about SAT and AO Alliance. SAT was formerly known as BSN Medical to most of the orthopedic surgeons. SAT is a global hygiene and health company headquartered at Stockholm, Sweden, and has presence in over 150 countries. AO Alliance is a developmental non-profit organization dedicated to improving the care of the injured in low and middle income countries. This is the fifth such program in a live webinar series happening every Saturday from 1 p.m. to 2 p.m. in the months of May and June 2020. And the topic for today's session is management of ankle sprain with heel lock technique. So I would like to welcome the keynote speaker for this session, Dr. Ajoy SM, who is a consultant orthopedic surgeon and a foot and ankle specialist at MS Ramaya Medical College and Hospital, Bengaluru. Dr. Ajoy is also an Honorable Secretary of Indian Foot and Ankle Society for the year 2018 to 2020. And joining the speaker, we have eminent panelists chairing the session. I would like to welcome Dr. T.V. Raja, who is an orthopedic surgeon and also a foot and ankle specialist. He's been a visiting consultant at St. Isabel Hospital, Visa Medicure, and Apollo Spectra, Chennai. I would like to welcome Dr. Swarnakumaar Dr, who is a consultant orthopedic surgeon at National Hospital of Sri Lanka, Colombo. We are also privileged to have Dr. Jim Harrison, who is a consultant trauma and orthopedic surgeon at National Health Service at Chester, UK. Dr. Harrison is also a regional director of AO Alliance for Africa region. He is also an honorary professor at University of Liverpool. The today's session would start with a speaker session. It would be followed by comments from the panelists where they'll be sharing their clinical experiences. And the last segment would be Q&A session starting at 1:40 p.m. So I would request all the participants to post their questions in the question box below the screen. And all the questions will be addressed during the Q&A session. With this, I would now request Dr. Ajoy to start the session. Over to you, Dr. Ajoy.
Okay. So, very good afternoon to every one of you. And, at the outset, I would like to thank SAT for having arranged this webinar and for having me give this address over here. And I would like to mention Dr. Raja has been the former vice president of the Indian Foot and Ankle Society. So he's also been in the field of foot and ankle for quite some time. Since I know that, I thought you had not mentioned it in your welcome, so I thought I'd add that up. Okay. Right, Raja. Okay.
Yeah.
Okay. And yes, let me just start off with, I'll be sharing my screen now. So we will be starting with the presentation on ankle sprains. So coming to the ankle sprains, let us just start off with this. So a brief overview. So we will first be looking at the anatomical facts of all the ankle sprains. Then mechanisms of injury which can cause this, predominantly the lateral ankle ligaments, which are the ones which we mentioned about. How do we classify them? How do we diagnose them clinically as well as by means of some investigations? And what are the treatment options available? But then in here, we would be restricting ourselves mainly to the conservative options, and we will not be discussing the operative options at all. Cool. Yeah, okay. So these are I was just mentioning what are the anatomical facts with regard to the ATFL, the anterior talofibular, the calcaneofibular, and the posterior talofibular. The attachments of this, almost a centimeter from the lateral malleolus, and it is about an inch extending from the lateral malleolus up to the neck of the. Okay, so that's the normal anatomy. So there's a natural stability which is there in the neutral position, and this is because the tight fit of the talus between the tibia and the fibula. So that's how it is, because the talus is wider anteriorly compared to posterior, and that's why whenever in a horizontal position, it is going to be a very nice fit and going to prevent any injuries from happening. However, when there is an increased plantar flexion, since the talus is wider in front and narrow at the back, so once there is a plantar flexion which happens, you can see that the narrower portion of the talus will come in contact over here. So when that happens, there is an excessive free space which is available. And at this stage, if there is a little bit of even a simple inversion stress which happens, it is going to lead to a sprain. So the first thing to go in this case is the ATFL, which is the ligament which is extending between these two and between their talus. So this is what exactly is happening. So the ATFL, which was horizontal in the resting position, is going to be vertical like this. There is enough room over here and there's not much of a snug fit. And the moment there is a small inversion injury, this is the normal. So the moment there's a small inversion injury, it is going to give way. Okay, so this is how the injury is going to happen. Okay, so this is the ATFL which is here. This is the AITFL, that's the anterior inferior tibiofibular ligament, which would be the next structure to go, and which we would be calling as a high ankle sprain, or wherever the syndesmosis also is involved. So we will come to that as we proceed further. Okay. So these are the predisposing factors to getting an ankle sprain. There is a biomechanical abnormality. There sometimes can be overpronation, there can be decreased flexibility, all of these. And improper footwear also can be one of the causes. So somebody with a footwear like this, where if you can see, the whole of the limb is in plantar flexion. And this is the most unstable way the foot can be, or the ankle can be. And just with a simple, just a touch, I think this lady could fall and injure her ankle quite significantly. Okay, so this is what would be the overall review as to which are the structures which are injured first. And like I told you, it is the ATFL. So ATFL is injured in almost 97% of the cases. So it's the first one to go. Then combined ruptures involving the ATFL and the CFL occurs in about 20% of the cases. So there would be ATFL plus the CFL, which would be involved in about 20% of the cases. Then there can be isolated rupture of the calcaneofibular ligament only in about 3%. So this is just about 3%. The PTFL is almost it's at the back. It's in a safe location, and very rarely it's injured unless there is a frank dislocation of the ankle. So this and this are the first ones to go, and then on, if at all, it would be this one. So very rarely you would get a sprain, an anatomical grade 3 sprain. So this is the ankle sprain classification which is being followed. A grade 1 is a microscopic ligamentous tear. There is very mild swelling. There is no joint instability, and there is little or no functional loss. In a grade 2, it's a partial tear with some amount of swelling and some amount of instability, and there's a moderate functional loss. And in a grade 3, it's a complete ligamentous tear. There's a severe swelling which happens. The patients who just come into us, they say that I can feel a ping pong ball which is there. So it's as thick as that. It is quite swollen in those cases. There can be a severe joint instability if it is left untreated, and it can lead to a severe functional loss. So these are the classification which is there, also called as the AMA classification. The AMA classification, the American Medical Association classification, is going to indicate a grade 1, the ligament is stretched. This is exactly what I told. It's a grade 1. A grade 2, it is partially torn, and grade 3 is completely torn. So this is the one which is going to cause the maximum instability and the maximal functional loss, the grade 3 sprains. A grade 1 sprains, sometimes patient may not even seek a treatment. A grade 2 and grade 3 sprains are the ones where patients generally come to hospital for treatment. There is another classification which is the anatomic classification. So in a grade 1, it is only the ATFL which is affected. A grade 2, the ATFL and the CFL both are affected. And in a grade 3, the ATFL, CFL and the PTFL are affected. So if we go by the anatomical classification, very rarely you might get a grade 3 sprain. Whereas if you go by the regular classification, the AMA classification, most of the sprains that we encounter and we treat are going to be a grade 2 or a grade 3 sprain. Okay. So how is the patient coming to us with? He is complaining of a popping or a tearing sensation. And if there's in cases of complete tear, so the patient is also unable to bear weight. So the ankle is completely unstable, grossly swollen, and the patient is unable to bear weight. So that particular history itself is going to suggest to us that it's a very severe sprain we're dealing with or a fracture we're dealing with. And an X-ray would definitely put to rest the presence of a fracture. And then we know for sure that we're dealing with a severe variety or a grade 3 ankle sprain in these cases. So the tests which we can perform, so this would not be performed in an acute setting. These would definitely be performed in a chronic setting. However, this are required to know to make a diagnosis, which is the reason I have just put these tests over here. One is the talar tilt test, in which we are going to hold the hind foot and we're going to look and tilt the ankle into an inversion. Once we perform an inversion, if there's a talar tilt which is greater than 10 degrees or greater than 15 degrees, or if there is a side-to-side difference of more than 10 degrees, then we are dealing with an ankle sprain in these cases. The other test that we can perform is an anterior drawer test. This, if the patient does allow, if the pain is permitting us to do, we can perform this test So we are going to stabilize the lower end of the tibia and the fibula, and going to give a forward thrust onto the hind foot and the ankle. So there is going to be a anterior translation, which is seen on this X-ray over here, which is going to indicate the presence of an ATFL or an ankle ligament injury. So this is performed in about 20 degrees of plantar flexion, because which I told you that ankle is most unstable in this position. So when this is done, a positive test is something wherein there is a increase in there's an anterior translation between half to a centimeter, or if there's a side difference of more than 3 millimeters. So only then this test is considered to be positive. So once we have done a clinical examination, the first thing, of course, we're going to get it done is the radiological examination. We do get X-rays in all these patients. X-rays may not reveal much with regard to the soft tissue injury itself, but we will definitely be able to identify if there's a fracture associated. The other things that we can do in these cases is to get a imaging done by means of an MRI scan. In the MRI, or we can go ahead and do an ultrasonography. So ultrasonography, we have a study performed in our own institution, wherein we were assessing patients' initial stage. On the day one, we would just be mobilizing them by means of a crepe bandage, or give them measures like the rise. And then on between 48 to 72 hours, we would perform an ultrasonography on all these patients with a 13 megahertz probe. So one that would reveal to us the presence or the absence of a tear and the presence of a just the ATFL or the AITFL tears. And we had a very good reporting which used to happen. We have excellent radiologists in our institution, due to which we are able to pick this up, and we publish this study also. There is other thing that we can do is to perform a bone scan. A bone scan is going to indicate the presence of suspected stress fractures, and a hot area can also be seen if there's a ligament which is injured. The other thing that we can see is get it done is to get a CT scan done. A CT scan would indicate the presence of a tarsal coalition or any reason for the foot being in overpronation. So all the risk factors can be assessed by performing a CT scan. And MRI is the most preferred one in most of these investigations. So that would be performed as a late stage. We very rarely do it in an acute stage, though it is done, not that it is never done. It is done in an acute stage to assess the nature of the injury, but then it is preferred, or it's almost mandatory to perform one in case of chronic sprains. So what are the things that can be done, or what can be? We can also assess the presence of osteochondral defects in this, and we can also look at tendon ruptures or any other things which have happened along with the ankle injury itself. Now coming to the management of the sprains, the basic principles in which the management is going to be is that a majority, all of these are with relation to the acute sprains itself. Majority of these grades 1, 2 and the 3 ankle sprain can be managed without surgery. So in an acute setting, I think very rarely any one of us performs surgery. We are going to go in for some kind of a conservative treatment itself. And only when the patient does not respond to a conservative treatment for a year or so is when we would offer surgical treatment. Or if we find there's something associated, like there's an OCD or there's a free fragment in the ankle itself, wherein we would suggest the other surgical aspects. But then most likely, if it is only a grade 1, 2 or a 3 lateral ankle sprain, we can manage them without surgery. So this is how the treatment generally goes: analgesics, rise, ankle or brace support, and cast immobilization only for about 10 days. And then on the indication could be, so for surgery would be extensive grade 3 lesion or massive hematoma. This is the algorithm that is normally followed. In case of an acute ankle sprain, the patient is informed regarding what all he can expect, what are the warning symptoms that we need to look out for. Then in the immediate phase, we are going to give some rest. So all the patients, I keep them non-weight bearing at least for a duration of 48 hours, at least 48 hours, irrespective of there being a very minor sprain. I tell everyone to be non-weight bearing for at least 48 hours to 72 hours. And then I reassess them, call them back, and we either perform an ultrasound or we do a clinical assessment. And then the ones which are having a mild ankle sprain, a grade 1 sprain, can immediately start off with an exercise therapy as soon as it is possible. In case the pain is quite severe, in case they are still not responding well to treatment, then we are going to give a paracetamol, and some measures to decrease the swelling. A topical NSAID is something which I don't prefer. This was there in this slide which was mentioned already. Therefore, I have retained it. But then I personally do not advocate a topical NSAID application, because the patient, if there is might start doing this, and if there is an associated fracture, and on their own they start doing this, they might miss miss out on the presence of a fracture, and time would be lost. That's one of the reasons I say that topical NSAID should not be used. Then if the pain does persist, then we can go in for oral NSAIDs, paracetamol. So in those cases which are much more severe, a grade 2 or a grade 3 sprain, then we go in for a semi-rigid or a non-rigid ankle support, and then on we are going to put them in a cast. So this again is like it's mentioned, it's a case by case. In severe ankle sprains, we're going to give an immobilization up to about 10 days to 2 weeks. But in the grade 2 sprains, which patient can bear weight, we're going to go in for a semi-rigid kind of a support by means of a semi-rigid cast, or we can give an ankle support, which is the air cast kind of an ankle support, which the patient can wear whenever is bearing weight and can take it off at times when it's not bearing weight. Then we are going to reassess these patients after, and if they're still unable to bear weight, then we are going to go with the immobilization of the cast and reassess them by a week to see what's the kind of improvement, and then on get the MRI scan and any other further investigations for these patients. So RICE is something which all of us know, which is something our staple diet. So R stands for rest, I for ice application, C for a compression, and E for elevation. So this is, once RICE is done, even the simplest injury can be treated, and very often even a complex injury can be treated. So next, once we do start rehabilitating these patients, we go in for proprioceptive exercises. The proprioceptive exercises can include this. You can allow the patient to stand on one pillow, on one leg on a pillow, soft pillow. So that would indicate this would be a very simple proprioceptive exercise. The other thing which I do to do a proprioceptive exercise is I tell patients to keep their foot hanging in the air, and using the great toe as a pen, try to draw out the letters of the English alphabet. So if they draw a B or a C in air, so the ankle is going through a full range of movement. So that is one of the simplest of the proprioceptive exercises, which can be performed at home itself. Patient need not go anywhere at all. So these are the other exercises which can be performed, wherein you offer resistance by means of a TheraBand, and you ask the patient to mobilize the ankle itself. This is something like a wobble board, and this is the actual wobble board, but then we have indigenized this also. So if you tell the patients that we need to do this, I think in Indian scenario, the chapati maker can act as a very good wobble board. So patients can do that also. So proprioceptive exercises would involve all these, but these are started only when the patient is pain-free, and only when we have confirmed that the patient can get back to a exercise module. Only then we are going to start this, and not in the initial first or the second day. So the other thing that we will do is to strengthen up the peroneal muscles. So these are the muscles which are going to act synergistically along with the lateral ankle ligaments to give stability to the lateral side of the ankle. So we are going to train these peroneals to restrict the extensive motion. And how we do that, we are going to strengthen them up. We give them a TheraBand and allow them to push against it against resistance. So once they do that, the lateral muscles are going to get strengthened up. The peroneals are going to get strengthened up quite significantly. So these are the other things that we can be allowing them to do: bilateral and unilateral heel raises, toe raises, and all of these are going to increase the range of movement, and at the same time are going to help go in for a functional recovery for the ankle. So these are the common things that we used to do, but what does the literature say? Have we been doing things correctly? I just had a look at the literature to see what has been coming up since the past few years. And way back, 22 years ago, there was something which has come in like a semi-rigid cast immobilization for the treatment of grade 3 inversion injuries of the ankle. And this has come from Turkey. And at that time itself, people were trying to see if you give a semi-rigid kind of immobilization instead of giving a rigid immobilization, does that improve the patient's outcomes? So those days, I think they were not following the proper outcome measures and all. However, they did find that at this kind of a treatment was actually quite viable, and it was possible that patients could go in for a semi-rigid kind of a cast immobilization instead of a rigid immobilization. So this is one of the studies, earliest studies which has come, 1998 itself. Further to that, 2003, I think that is when again the similar kind of assessments were being done, and this was done on a biomechanical assessment. In a biomechanical study, they found out that if a semi-rigid cast is applied, a synthetic cast is applied, then compared to a rigid synthetic cast, they found that by biomechanical testing, they found that the region which needs to be immobilized can actually be immobilized very well. So in the case of the ankle, if a heel lock method is performed, then the ankle itself is quite stable. Whereas the surrounding smaller joints, supposing we are talking of the talonavicular joint or the mid-tarsal joints and all, or the metatarsal phalangeal joints, all of these are going to be free. They are going to be quite flexible. So the patient can go in for a functional kind of a rehabilitation. At the same time, the ankle itself, the inversion and eversion itself can be prevented by performing this. And this was proven by means of biomechanical modules, and they had performed 10 cadaver specimen and checked it out and had proven this quite well. In the year 2003 itself, it was published. So then after that, what has been happening is people have been coming out with studies and all, a meta-analysis of which has come in the year 2013 itself. And this was also evaluated all the different kinds of injuries, treatment, acute ankle injuries and treatments for each one of them. And they have also found that it is possible that patient goes in for a semi-rigid kind of a fixation, casting or immobilization instead of a rigid immobilization. Or if he goes in for a rigid immobilization, he immobilizes it only for 10 days, and then he goes on to a functional rehabilitation. So all of them have come out with functional rehabilitation as the undercurrent, or that being the underlying statement in each one of them, that it is functional. The functional rehabilitation is the best one, including Nick Van Dyke. So even he had come up with a study and which was published in 2011. And in fact, the Cochrane review, which is there, which was shared with me, is also been authored by Professor Nick Van Dyke. That's Professor Nick Van Dyke, whom I had met with during the Jaipur Foot and Ankle Congress, which he had come in for. It was an excellent session where he spoke at length about ankle injuries and his own methods of treatment, most of which have been carried forward and most of which have been included in today's talk itself. So he is in favor of always a semi-rigid kind of a casting or a functional kind of a rehabilitation. So functional treatment appears to be a favorable strategy in the initial stage itself. So what we used to initially do, that whenever there's an ankle sprain, put in a plaster cast, keep it for 6 weeks, is not the kind of treatment we should be looking at. So only in cases of an high ankle sprain, wherein there is an associated ITFL injury, is when we should be looking at a rigid immobilization. And that also should not be for very long. It should just be for a period of about 10 days. And after the maximum period of 10 days, we have to start off with a functional rehabilitation for this patient. So this is where the role of a semi-rigid kind of a casting comes in. And a soft cast is what we can be using to allow these patients to get back to work quite easily and very early. This is one of the surgical options which is available for treatment. Once the patient has not responded to any conservative treatment, is when we consider a surgical option. And most of my patients, I perform an ankle arthroscopy. So this is the arthroscopy portals to address any other internal pathologies which are there, say like an osteochondral defect or loose bodies or whatever is there, or increased synovitis and all can be treated. And this is the mini incision, the mini open kind of a procedure, wherein we identify the ATFL which is there, thinned out and torn, and the CFL which is here. Sometimes it's generally these two which are the problem areas. So these can be double-breasted and procedures such as the Brostrom Gould, wherein we also use the extensor digitorum, the extensor retinaculum. A slip of that is taken and sutured it to reinforce it. So that's the anatomical reconstruction, anatomical repairs is possible. The presence of syndesmotic injuries. How frequently do these occur? They occur almost to the tone of about 10 to 18%. So this is known fact, and we were able to reassess this by performing ultrasonographic examination on all our patients. So about 66 patients were examined in sequence, and we found at the end of day 2 or 3, we were able to identify that almost about 20% of them had got syndesmotic injury, which needed some kind of an immobilization. The others would definitely go in for some kind of a functional rehabilitation alone. So this is the conclusions that we had from that. So the diagnosis of these could be established very well by performing the squeeze test or the external rotation test, and then on we went on for the cast application. So summarizing this, these are common injuries in a day-to-day practice. The clinical diagnosis is the key. Then we need to isolate the syndesmotic injuries. These are the ones which would need some kind of a rigid immobilization. There is a semi-rigid kind of a casting which is available and which does play a significant role. Investigation is important to make a diagnosis. The surgical indications and procedures are very, very clear, so not everybody needs surgery. And rehabilitation is also equally important in these cases. Now I have a couple of videos here which I'll just share with you. So this is how the heel lock technique is performed. So if you're looking at this, so that's how we're going to prepare ourselves. There's a stockinette which has been utilized here, but generally what we get here is something called as a delta drive stockinette, so which is much better than this. This is a Tricofix kind of a stockinette which is available, but now we have better options which do also give some amount of a so that's the exact heel lock which has to be performed, because if you can see that the way the plaster cast came in, it came from below and it went around the heel and locked it up in position. Just to reinforce that, let me just take you there again. So there, okay, it's here, okay. So there you are. You can see that's the kind of a heel lock which is performed. So once this has been performed, the ankle is quite stable. Okay, so and then we can complete off the rest of the casting. So the excess cast is just trimmed off for the time being, and the stockinette which is there. So this is the regular Tricofix kind of a stockinette, but then we have a delta drive stockinette which is available, which is what we can use here in our setting, and roll that back, and then we're going to complete the rest of the cast. So once this cast has been performed, you can end it up quite well. So you can make it look as aesthetic as possible. Once that is done, we're going to just check out if the patient is able to perform an inversion and eversion. So that's the amount of inversion which is possible on this side. That's the restriction which has been brought about by this kind of a cast. So the heel lock has prevented the inversion from happening. So that's the amount of inversion. That's the prevented inversion. Okay. Then is it very uncomfortable for the patient to walk? No, it is not. You can just see them. So it's as good as anything. So the patient, you would hardly know. And if you put in something with the colors that the patient would like, I think that would be nothing like it. So what about dorsiflexion, plantar flexion at the ankle itself? Is that restricted? No, it is not. So you can see that most of the regular activities can be performed, but the thing that we need an immobilization for, which is the inversion and eversion, is the one which is going to be prevented. Okay. So thank you all for a very patient listening. Now let us go on to see what all we can do. Okay.
Thank you, Dr. Ajoy. Now we move on to the next segment of the program, where we'll be listening from the panelists on the comments of the speaker session, and also they'll be sharing their clinical experiences on the management of ankle sprain. So I would now request Dr. T.V. Raja to start giving his comments.
See, I would like to say about a few things which are more important. One, you saw Ajoy showing you how you use the heel lock technique. One important thing, what are the advantages of doing the semi-rigid casting or the delta soft? One, if you use your Delta Dry soft roll padding and use a Delta Soft, the patient can wet the cast. Semi-rigid cast can be wet, and if it is allowed to dry on its own or shown in sun for 5 minutes, it gets dried, so you can use it normally. Only when you use a Tricofix or a soft band padding, you're not allowed to wash it. That is one advantage. Another thing, if you see the heel lock technique, what Ajoy showed, you can see he takes it from the high of the heel down to the plantar surface. So it is nothing but there is a band that comes from the lower end of fibula to your plantar surface. And there is little bit of stretchability in your plaster. So that is the amount of plantar flexion that is allowed, and it restricts your inversion. So the ultimate aim is it allows you to do all your movements with restriction. The terminal degrees of all the movements are restricted. This is the very important thing on using this your Delta Soft. Another thing is, normally what we do in the clinic when we see a patient with ankle sprain, normally we tell them to give ice pack, keep the leg elevated, analgesics, and give them an elastoc grip bandage. What does the elastoc grip bandage do? Normally when you give an elastoc grip bandage, the patient has normally when they get a itch or something, they remove it off. So patient compliance is bad with an elastoc grip bandage. The same way when you give an air cast, you tell them not to remove it while walking. They will wear it for about a week's time, and after that what they will do is they'll remove when the pain comes down, then get a recurrent ligament tear. So the advantage is patient will not remove this because it is a semi-rigid cast. They will come back to you in 2 weeks for removal. Okay, what are the patients I've treated with semi-rigid cast? Normally all my stage 2 ankle sprains go with semi-rigid casting, or it is called as Delta Soft. For 2 weeks I give them. After that I start them on all the exercises that Ajoy told you. Normally they recover very well if it is stage 2. The stage 3 is the little bit of borderline cases. If you keep them for about 4 weeks, and then you can change them onto rehab exercises with an ankle brace. They do recover, but you will have to repeat the MRI after 6 months to see what is the amount of healing in ATFL and CFL. Because normally healing happens by fibrous tissue. If the fibrous tissue is strong enough, they hold very well. But if the person is a sportsman or going in for active sports, then the chances of the fibrous tissue can break down. That is where Ajoy showed you the modified technique of Prostom Gold, where you do a repair, or you can do a arthroscopic repair as Van Dyck does. So these are some of the things. I've treated a lot of patients, sportsmen and the regular patients, and people who wear high heel shoes and are not properly walking. They normally walk with 10 degrees of knee flexion and 10 degrees of hip flexion with a lumbar lordosis. Whoever walks with a high heel more than 2.5 inches, they are people who are prone for this ankle sprains. Normal general crowd who wear heels, who are little obese, and who are not used to walking with 10 degrees of knee flexion and 10 degrees of hip flexion. So otherwise, sports people, they do a good rehab, they get away with it. But normally I do a review of MRI after 6 months. So this is my protocol. Thank you.
Thank you, Dr. Raja. Now I would request Dr. Swarnakumaar to share his comments and clinical experiences.
Actually, it's a important thing to assess the patient clinically, and at some stage we have to do the MRI scan. We should not forget, especially these patients when they come with recurrent instability. So when they are treated with flexible or rigid cast, still I am against this rigid cast using for about 4 to 6 weeks, as Ajoy said. We have to mobilize as early as possible, about 10 days to 14 days. And when they keep for a long time, they get stiffness. And when they come with recurrent instability, so we have to do the MRI. You will no need to wait for 6 months. to assess the ligamental tear, then we have to plan for surgical intervention if necessary. And I appreciate Dr. Ajoy's work that how to use this heel lock technique. It's a very effective technique when we apply this soft cast or semi-rigid cast, or even when we are applying the rigid cast also the same way it has to be applied. So it gives better stability of this ankle to prevent further injury and to stabilize that. Thank you.
Thank you, sir.
Thank you, Dr. Swarnakumaar. Now I request Dr. Harrison to share his comments.
Thank you very much. Yes, well, thank you, Dr. Ajoy, for a great talk. I certainly learned some things from your talk. I'm more of a general trauma surgeon, and these specifics of foot and ankle surgery are really helpful to people like me. I fully agree with the approach that's being taken. I think we do something very similar in UK practice in terms of a big shift towards functional treatment programs after ankle ligamentous injuries. So when I was a youngster and a registrar training, then often people got put in rigid casts for maybe 6 weeks or something, and we've moved right away from that. So I think that's a really strong message that's coming out. We're all agreed that that's not the best treatment. And if we do use a rigid cast, we wouldn't want it beyond 10 days. So that's great. Just one thing to highlight, and it was in the talk, but I think it's a good thing for us to note, even as general orthopedic surgeons, is just keep an index of suspicion for osteochondral injuries associated with sprains. And often if you're really looking for it, then even on the plain imaging, you can have a suspicion that there's one there. There's usually just a hint of a lucency on one corner of the talus. So just keep an eye out. That they're not common, but they're not that rare either when you start to look for them. And so that's just one tip that I'll emphasize, but it was there in the talk. Thank you.
Thank you so much.
Thank you, Dr. Harrison. Now we move on to the next segment, the last segment of the program, which is the Q&A session. So I'd like to address this question to Dr. T.V. Raja. The question is, in rigid immobilization, the duration of treatment would be around 4 to 6 weeks. But does the duration of treatment reduce with the usage of semi-rigid casting? That's his question.
There are two things when you talk about rigid as well as semi-rigid. First thing is, you will not have stiffness. Post-treatment stiffness is less with semi-rigid casting. Whereas when you leave it for 4 to 6 weeks on a rigid cast, there is stiffness, post-treatment stiffness, and patient goes for a longer time of rehab. And scientific papers have shown when you treat them with semi-rigid casting, the healing is better because micro movement advances healing, and healing is better when you have a micro movement. And you preserve other ligaments when you have limited movements. And non-use atrophy is reduced when you put them on semi-rigid casting. When it is rigid casting, you have non-use atrophy. So that is the main thing. So always it is better to be on semi-rigid. Healing is faster, rehabilitation is less, and non-use atrophy is less. And some patients where I've seen, even in 6 weeks, you keep them on plaster, they go for Sudex. So that is a biggest problem. So sooner you get them back to work, it is better.
Okay. Any comments from the panelists?
Yeah, I agree with Raja. Actually, the main problem we get in is ankle injuries, they get stiffness. So when they keep for 4 to 6 weeks, so I'm totally agreeable that it has to be a guided management. The patient has to be followed up in weekly interval to assess the stiffness and go for a flexible or semi-rigid casting to mobilize as soon as possible to get, as he said, to balance the other ligaments.
Yeah, that's what. So one of the things that was asked was whether we keep it on for 6 weeks. I think yes.
No. When it is grade 3, you keep it for 6 weeks. Otherwise, you can do. And another thing is, for 6 weeks, single casting will not hold good because it has got elasticity. You will lose the elasticity in about 3 weeks. So you can remove the plaster in 3 weeks, reassess the patient, and then decide what you want. Same plaster, which has got an elastic component there, may not have the same elasticity at the end of 6 weeks, and 6 weeks may not be necessary for grade 2. Grade 2, 2 weeks will be enough. Whereas when it is a complete thing, always the patient, you will do an MRI by end of 10 days. When the edema settles down, when the patient presents, then you do an MRI, you know what stage you are handling. Depending on the staging, you decide. But by end of 3 weeks, I think you can remove, reassess the patient. And if you want to put them on a cast bracing, you can go ahead. Or if you think this is better, you can redo it.
Yeah.
So it will be fresh. Another thing is, by 3 weeks, when you are going to do the plaster on day 0 or day 1, where there's a lot of edema and hematoma, in 15 days or 2 weeks, when you talk about, the edema is going to come down, the patient is going to come back to you and say the plaster is loose.
Loose, yes.
Yeah. So then you will definitely have to redo it. So one roll of plaster, it doesn't matter. Scientifically speaking, it is better. When it is very loose, then it doesn't serve your purpose.
Right. And, yeah, because then sometimes we do allow them to wash it up and all, because we feel water does inside and all, it becomes a little soggy.
After 15 days or 20 days, you can remove it, reassess. Whomever you want, you can leave them free, ask them to rehab. Whoever are finding it difficult, have got little more pain and ankle is not stable, or at least at the stage you decide whether the patient has got an osteochondral defect or anything, you do an MRI at least at that stage on 21 days, then reassess and plan from there on. I think that is a good idea.
Okay.
I want to ask one question. When you keep for 6 weeks with the rigid cast for type grade 3 injuries, yes. So how do you advise the patient for weight bearing?
So that is what I was telling you. I don't normally keep the same plaster for 6 weeks at all. 3 weeks, I do a reassessment of the patient.
Yeah. At the end of 3 weeks, you reassess.
3 weeks, I remove it. Yeah. And another thing, if you're going to put them on rigid casting or semi-rigid casting, after 3 weeks, you will have to definitely allow them on weight bearing.
Weight bearing, yes.
ATFL or ankle sprain with weight bearing, nothing happens. On a dorsiflexed ankle, load is going to get transferred from the calcaneum talus straight into the tibia. Only weight bearing on a plantar flexed ankle gives you problem. And when you have a semi-rigid cast or a rigid cast or a air cast, everything, ankle movement is restricted, and they are normally on plantigrade foot, they are allowed to walk. Maybe depending on the pain, you can make them walk partial weight bearing or full weight bearing with support.
So that's the message we have to give, because some patients, they are kept for non-weight bearing for longer period. So these
they all see, if you keep them on long term on non-weight bearing, they go for non-use atrophy, and that is the biggest headache you will face. Ligament will heal, the bones will become weak, and patient is apprehensive to start movement.
Yes.
That is the common problem.
I fully agree with this. I think it's really useful to get them weight bearing early. I think that's better.
See, the idea of semi-rigid casting itself is early mobilization. Yes. Now we are moving towards early mobilization and patient getting back to work, patient going back to office. So that is why semi-rigid casting came into play from a rigid casting. So the whole concept is about early mobilization.
And we haven't talked about venous thromboembolism at all, but obviously there's also an advantage in that, in having both movement,
definitely an advantage.
Bearing. So this gives a huge advantage for that.
Yeah, yes, definitely, yes.
Yeah, I think so. I think more or less the need for a rigid casting is now relegated only to that where there's an associated syndesmotic injury or an AITFL injury.
Or a bony injury.
Yeah, only then I think. Otherwise, I don't think we should be even attempting to go in for a rigid casting at all.
The concept of rigid casting is almost gone for
outdated, completely gone, completely outdated. Yes.
Thank you. We'll move to the next question. This question is related to the discussion just happened. So this question is directed to Dr. Swarnakumaar. The question is, when the patient is on rigid immobilization with regular plaster cast, what are the general issues faced by the patient, and how do you address those issues?
Can you repeat the question again? when he is on rigid cast?
When the patient is on rigid immobilization with plaster cast, what are the issues generally faced by the patient and how do you address them?
Yes, that's what I addressed before. So these patients, when they keep for a long time on a rigid cast and immobilization, they get stiffness. It lasts for a longer period. If they come with repeated pain and stiffness, and they can get thoracic atrophy and disuse osteopenia and osteoporosis, and also joint stiffness of other joints, not only the talotibial joints, other joints also undergo stiffness. It will be a chronic pain management problem when we remove the plaster. So that's the reason that we want to go for a semi-rigid cast and full immobilization. So we have to address it as early as possible to immobilize with pain bearing.
Okay. Any other comments from the panelists?
No, I think more or less plaster disease. I think that's something which all of us know, that whenever you immobilize things for longer, we end up with all the symptoms of RSD or sympathetic dystrophy, which is always there.
Okay.
I think you really have to ask yourself why you're using a rigid cast. And in most cases, I think it's sort of over-treatment, if you like, or fear of this from the surgeon or the treating person. And it's normally not in the patient's best interest. If there really is some instability that requires a cast, and that's usually outside of the scope of this talk, maybe with an unstable ankle fracture or something, then ask yourself whether you might be looking towards an operative approach if you have that facility. But I virtually don't use rigid casts at all in the lower limb now. I still use them in the upper limb. But for lower limb injuries of all kinds, I use functional braces, or if there's really instability, then we tend to move towards an operative approach.
Okay. So we on to the next question. The next question is addressed to Dr. Harrison. The question is, what is the management approach in developing countries for ankle sprain? Is it different or is it same? And he hasn't added another question. What is the typical patient profile seen there? Is it more of a sports professionals or regular active population?
Thank you. Well, in terms of developing countries, I think we always have different facilities available, and I think you work within the facilities that you've got. But the principles of treatment are the same, and the understanding that a weight-bearing restricted mobilization approach is ideal, is what we should all be aiming for. There are some situations where you can't do semi-rigid casting because those materials are not available, or even braces may be quite limited. So what you might do is a short period of a more rigid cast, but I wouldn't want to go more than 2 weeks normally for that. If you've got a grade 3 injury, then you've got a difficulty there. If you really don't have any bracing or any semi-rigid casting, then it's more difficult. You might go for a more rigid casting up to about 4 weeks, but I would get the patient walking in it. And actually the casting will tend to weaken over the period of time with the patient walking, and that will allow its own sort of dynamization. So I think in our head we have to get the concept that we want to get the patients with a controlled movement, avoiding unstable inversion, and with weight bearing as soon as possible. So I think that those are the key principles, and then you use your materials as best as you can to achieve that. Certainly MRI scans and things are not normally available widely in low-income countries. And even in the UK, we use them fairly cautiously. But I think a plain radiograph is often available. And with a careful look at the plain radiograph, you can look at the integrity of the ankle mortise, check for any fractures, and look for any osteochondral injuries. And I think you can pick up most of these injuries with plain films. Thank you.
With regard to the patient profile itself, there was a thing on what's the kind of patients that you normally see? Is it somebody who's an athlete, or it's
Okay, yes. Well, there's all spectrum of people in every country. So ankle injuries are in Europe, they're more common in women. So it's 2-to-1 female to male. My experience in Malawi and the African countries, I think it is a little bit more even match. And you still see quite a lot of people that have ankle injuries just playing football or playing netball or similar sports. But they may not be professional or elite sports people, but sports injuries are common, and others get them with work or with moving to go and carry water from the well or things like that. So these are common injuries, mainly in young people.
Okay.
Thank you, Dr. Harrison. Any comments from the panelists on the patient profile which you normally see?
So more or less, even we get a mix of patients. It's somebody who's just gone for a party, just returning from the party with a high heel footwear. I think they just goggle over. I think these are quite common things we do see. These are the late night patients that we see are generally like this. The early morning ones are the sportive kind. They went exercising or something, and then they came
Tripping
back.
from the platform and the road while walking in the morning.
Yes.
Hangover. That's a combination.
Yeah. I think so, yes.
I would like to ask one question. So, we have been talking about ATFL injuries, but when there is a deltoid ligament injury type 1, so how do you apply your locking, heel lock technique, Dr. Ajay?
So when we're doing that, see in this case, we are going to go only once on the lateral side and this way.
There you'll have to go on the medial side also.
Medial side also like that.
Here
this way
you're
up,
using
down, that way and down. Like a figure of 8.
You'll have to use it like a figure of 8. And another thing is, here you're using only one roll. Very important thing when you're using a semi-rigid cast, do not use 2 or 3 rolls.
Yeah.
Again, it'll again become like a rigid cast. Because early days, in about 3 years ago, 4 years ago, I've tried that, and you'll land up in trouble. It'll again become like a rigid cast. So it is only one roll. You'll have to plan for the length and do only one on lateral, one on medial. That's it. That will take care. Early days I've done that, and I've seen it becoming also bulky, and the patient will not have movement and very difficult to walk. What will happen is the front edge will come and press on the shin of the tibia, and they'll get a lot of pain and they don't walk. The flexibility is not there. It will become tight around the ankle joint.
Right.
Okay. So the next question is addressed to Dr. Ajoy.
Yes, sir.
The question seeks more clarification on the actual indications for surgical management in ankle sprain.
Okay, so in ankle sprain, so if we are talking of an isolated lateral ankle sprain, then it is something the patient who's got mechanical instability, not functional, mechanical instability. We need to reassess this patient. We need to make sure that it's a mechanical instability by performing the different tests which I mentioned, the talar tilt as well as anterior drawers, and also documenting this sometimes by means of a stress radiographs also. So these are the ones, a year of conservative treatment failed, having definite mechanical instability would be the ones who would go in for a surgical approach.
Okay.
Okay.
Any other comments from the panelists?
For ankle ligament surgeries, lateral ligament surgeries, the results are very good only in trained and very good hands. Either you can do it arthroscopically or you can do it openly. You can do it only ATFL repair, or you can do ATFL with CFL repair. So there's no more comments. Good in good hands. That's the first thing that is written on the book. And because I've seen Van Dyck doing arthroscopically, and we have tried it, but the results are not good when you do it. But open technique, yes, the results are very good.
Very replicable,
and
yes.
Selection of patient is very, very important when you are doing a repair for ATFL. That is more important, because rehabilitation is for a little longer period. You will have to rehabilitate the patient to get back normal range of movement. This is something like your supraspinatus tear of your shoulder when you do with your AC joint, how long the time takes, the same story here. So you'll have to educate the patient well priorly before taking the cases. Selection of cases when you do an ATFL open repair is very important.
Right, that's what I told you. The only ones who are mechanically unstable, where we have a demonstrable instability, are the ones who respond very well to treatment. I think only those functional unstable kinds who feel that they've got an ankle which gives way, and you don't find any instability when we are actually testing them, I think they wouldn't do very well with a surgical approach. The differentiation is quite important.
So, minor types of these eversion injuries, we usually go for rigid cast. Dr. Ajay, have you tried any semi-rigid cast for these type of minor eversion injuries?
Minor avulsion fractures? Yeah, minor avulsion fractures also, because these are actually the bony kind of an injuries only. They do well, but I haven't used them in avulsion fractures, no.
Okay.
Those ones I generally tend to give a little rigid cast only in those cases. So I treat them almost
you
like
can take it like this, sir. When there is a bone involvement, go for a rigid.
Yeah, that's right.
Then you can probably initially the 3 weeks will be on rigid, then you can go for a semi-rigid cast. I've done tip of fibula avulsion fractures I've done. Previously, what I used to do was I used to put a K-wire and then put them on a plaster. I used to put percutaneous K-wires and then I used to put them on plaster. Nowadays, you can put them everted. Once it gets reduced, in that position, you put a plaster and leave them. And later on, same way, when I said 3 weeks, you remove the plaster, then go for a semi-rigid cast. So that, see, semi-rigid cast is nothing but it is like a cast bracing.
Yeah.
You have all directional movements, multi-directional movements are there, but terminal range is restricted. This is the whole concept of a semi-rigid cast. And how much ever you want to restrict, you can restrict by putting the plaster. It is the technique of the plaster. It is nothing but when you are doing a rigid cast, it is like your twine thread. Delta soft or your semi-rigid is like your rubber bands. It's exactly that.
Yes.
Non-stretchable, they are like twines, multiple threads, cotton threads, that is your rigid cast. Your elastic rubber bands, multiple rubber bands is your semi-rigid. That's it.
Thank you, Dr. Raja. The next question is addressed to Dr. Raja. The question is, how does the duration of physiotherapy reduce because of using semi-rigid polyester cast?
See, very important. First thing, how it reduces. One thing, there is no non-use atrophy. You're not resting the movements. And other joints, you are not holding with a rigid cast. So there is other joints, movement is preserved. Other ligament movements you are preserving. And only the terminal range of movement is stopped by semi-rigid cast, as I told you earlier. So only the terminal range and proprioception has to be taught, and patient is walking still. So even proprioception is preserved. So only minimum rehabilitation is required with your TheraBands and your wobble boards at the last stage. If the patient is on semi-rigid, normally you educate them with the exercises and then give them a printout of the exercises and send them. They will do the exercise and come back to you after a week. And again, one more week, they are absolutely normal. If you put them on rigid casting, they will have to come to the therapist to get rehabilitated. I've seen patients on rigid cast where I've even done wax mobilization of the ankle. The ankle becomes stiff because there's a hematoma. Immediately after injury, there is hematoma. You put them on rigid casting, the hematoma along with the injured tissue forms a fibrous tissue. If suppose there's a osteochondrolation, everything forms a big hard mass on that side, then you'll have to do a wax and gradually start stretching it. I've done that for patients. So I would prefer semi-rigid cast or the delta soft.
Okay. Any comments from the panelists?
No, nothing. Fully agree.
Yeah. So we'll move on to the next question. This is addressed to Dr. Ajoy.
Yeah.
The question is, since in ankle sprain, the major problem is the recurrence of ankle sprain. So is there any evidence which says that using semi-rigid casting or any functional immobilization reduces this chances of recurrence? Is there any clinical evidence on that?
Okay, so the recurrence of the ankle sprain generally happens mainly because the rehabilitation did not happen quite correctly. The healing did not happen. So if the ligaments healed in a stretched position or in a rigid, contracted position, is when there is a chance of getting a recurrence of the sprain. Whereas if you rehabilitate or you treated this patient functionally, the length of the ligaments is going to be retained. So the chances of getting a recurrence is much lesser in these cases.
Okay.
The exact numbers I don't have. I didn't go through those references completely, but then there definitely must be studies which have shown this. Dr. Raja, anything?
Comments from the panelists?
Only one I like to add up. Ajay, can you say it like this? After the ATFL gets injured and healing happens, the healing happens with the fibrous tissue. So basically what happens is the recoiling capacity of the ligament goes. Recoiling capacity of the ligament goes. Either it is stretched or it is short. And there is little bit of fibrous tissue. That is why you don't get the same strength of the tendon.
Okay.
Yeah, I had a quick look ahead of this, and there seems to be some variation in terms of the reports on recurrent injuries, where some literature suggests that the non-operative approaches, including even the functional treatments, give a slightly higher recurrence rate than the surgical approach for the grade 3 injuries. And I think this is probably the reason that with elite sports people, if possible, some foot and ankle specialists advocate early surgery for grade 3 injuries. But I think for normal people, the risk of recurrence, if given a functional approach such as the semi-rigid casting, the recurrence rate's fairly low, perhaps somewhere in the 10 to 20%, and those cases could be picked up with a salvage operation later if required, and even salvage rehabilitation treatment sometimes works for the.
Yeah, I would like to add up a point. It is exactly like tendo-Achilles injuries, acute ruptures. There's a controversy that goes on whether surgery gives you good results or conservative. But there are a lot of studies from UK which shows conservative treatment of tendo-Achilles injuries proves to be better compared to open. But in India, the takeaway message is normally ATFL injuries and CFL, we don't operate at first sitting. Before we decide them on surgery, it is going to be minimum 1.5 years to 2 years. If they repeatedly come to your clinic and bothering you with recurrent injuries, only then they are taken up for surgeries. Never we take them up like tendo-Achilles for repair. Tendo-Achilles at least we take, and now there are a lot of papers. I think recent paper I saw from UK was a person has treated it for 1,000 cases of tendo-Achilles injuries treated conservatively. I think Ajoy knows it.
Yeah.
There was a presentation, meta-analysis with tendo-Achilles injuries, conservative management with us. So the re-rupture rate was in conservative as well as surgery, it was almost nearly the same. It is about 14% if I'm correct.
Right.
Okay.
And with regard to these ankle ligament injuries itself, so recurrent injuries, there's more chances that there will be associated injuries also with it. Like OCDs and all would have also developed. I think that would probably need some. So primary surgery, I still feel it's not in our hands. we don't agree to that.
Yeah, we normally don't do the first sitting surgery.
Yeah, that's a general practice. Even grade 3 injuries we manage conservatively in our country, Sri Lanka. So as Raja said, we wait for the patient. If they bother you, if there is significant instability, if there is significant pain, and then we consider to go for further intervention. So otherwise, we manage conservatively.
Okay, so in the interest of time, we'll take one last question. This question is open to all the faculty. The question is, in rigid casting methods. While removal of that, we use cast saw. Is it different with semi-rigid casting?
You can use your scissors and cut it off. No, semi-rigid, you can do it. So anybody who knows the heel lock technique, they can do it, and it can be cut with the ordinary scissor. Regular scissors, you can cut the soft. No saw is required for it. No special equipments are required for putting a
or removing
semi-rigid
or removal,
or for removal, both.
Yeah.
So it is, you need to learn the technique, and anybody can do it.
Yeah, that's it.
And
so with that, we come to the, please go ahead.
One thing to add on, if suppose a general practitioner, you are in a rural practice, you don't have an orthopedic surgeon, you are a general surgeon who's seen the patient with an ankle swelling, you don't know what it is, definitely you can take an x-ray, see if there are no bone injuries with an ankle swelling more on the lateral side, you can put a semi-rigid casting and then transfer the patient to the city to see. There's nothing wrong in putting a semi-rigid casting. Whereas rigid casting, if you don't know, you cannot put.
You shouldn't, yes.
Yeah, semi-rigid casting you can put, ask them to keep the leg elevated and you can transfer. It is little more advanced than an elastic rib bandage.
So with this, we come to the end of the program. So before we close, any closing comments from the panel members and the speaker? I can start with Dr. Ajoy. Yeah, Dr. Ajoy, yes.
Yeah, nothing very specific. So just that I'm quite thankful for all of you, all the panelists, and as well as to the SCT for having given this opportunity and for us to discuss so much. And we also kind of re-emphasize and we also strengthened our own principles. And we also relook at what all we've been doing. Different viewpoints, I think, added quite a bit to the treatment and management of our patients too. Thank you.
Again, I thank you, Dr. Ajay, that this is a very updated presentation, and it has changed so many management plans, I think, mainly for the junior orthopedic surgeons. So those are the trainees. They have so many things to take from this webinar from Dr. Ajay's presentation. Thank you so much for your very comprehensive, elaborative presentation. Thank you.
Only one take-home message: when you're putting the delta soft or your semi-rigid cast, do not stretch it much. The principle is exactly like elastic rib bandage. If you stretch it much, it will become more tight. So just go ahead and roll it. Do not stretch it much. That's the only advice. It was a very good program. I thank SCT for this opportunity. Thank you all for sharing your knowledge.
Thank you.
Thank you again. Thank you so much.
Belagitam. Thank you.
Yes, thank you.
Thank you. Yes, it was a pleasure
Thank you so much.
to join in. And I think we're all very agreed in advocating a non-operative approach for ankle ligamentous injuries, a functional approach with early control movement, early weight bearing, and an index of suspicion for hidden and other injuries that may be associated and may cause ongoing problems. So thank you.
Thank you.
Thank you.
Thank you. Thank you so much.
On behalf of SCT and EVO Alliance, I would again like to thank the speaker and all the panelists, and especially all the participants for making this a great learning experience. A couple of important announcements before we take leave. I would request the participants to share their feedback on the email ID mentioned in the bottom of the web page. And if any of your colleagues or team members could not access this webinar program, they can access it with the same link for the next 1 month. They can rewatch the webinar. And the next live webinar is going to be scheduled on 20th June from 1 p.m. to 2 p.m. And the topic for the session would be Management of Pediatric Fractures, Challenges in Daily Practice. And the keynote, the faculty would be Dr. Vikas Basa, who is a consultant at Pediatric Orthopedic Surgeon at Kokilaben Dhirubhai Ambani Hospital, Mumbai. And we also have Dr. Taral Nagda, who is a consultant at Pediatric Orthopedic Surgeon at Hinduja Hospital, Mumbai. We also have Dr. Pabin Thapa, who is an assistant professor of orthopedics at Manipal Teaching Hospital, Nepal. And we're also privileged to have Dr. Thaddeus Longo, who is a senior consultant, pediatric trauma and orthopedics at University Children's Hospital, Bern, Switzerland. So we hope to see you all and your colleagues in this webinar scheduled next Saturday on 20th June from 1 p.m. to 2 p.m. So thank you once again, everyone. Please stay safe. Thank you.
Thank you.
Thank you.
Thank you. Thank you, everyone.